responsible for each type of diarrhea. Then we'll briefly look at the 7 principles of management. Within the lecture, we'll discuss about prevention and certain complications, right? Okay. You should, I strongly suggest you to take notes, right? Okay. So you need to know the definition of diarrhea, right? The diarrhea, the definition of diarrhea is a passage of 3 or more watery stools within a day. But this definition does not apply to neonates. As you know, neonates generally open their bowels 10 to 15 times a day based on their breastfeeding frequency. And even if you pass several times a day stools, but if they are not watery or liquid-like, then still we do not consider it as diarrhea. So one of the first things in the history you need to decide is, are we dealing with a diarrhea or not? So diarrhea 2 types. You have the acute diarrhea, that is, if the duration of diarrhea is less than 14 days, we call it acute diarrhea. But most of the time, these diarrheas last for a few days rather than 13 days. But once the duration is beyond 14 days, we label them as persistent diarrhea, or sometimes we label it as chronic diarrhea. We'll have a look at the causative organisms. So most of the diarrheas, almost I would say more than 75% of the cases, are due to viruses. Few are due to bacteria. Even fewer are due to parasites. Now, one common misconception about these diarrheas within the community is that diarrheas are caused by worms. But as you will find, or maybe I may have discussed in one of the CLDs also, we don't see much worms these days, so it's not a major cause for diarrhea. Remember that. So these are the viruses. As I said, more than 75% of them are due to viruses. Rotavirus is the #1 case, especially in the first year. Then, so you need to know some names, right? Adenovirus, enterovirus, like that. Bacteria account for about 10 to 20%, depending on the community. Most of them are, at least the majority, cause blood and mucus diarrhea, except cholera. Cholera causes a watery diarrhea. You call it rice water diarrhea. Then E. coli, as you know, there are 4 types of E. coli. Out of those, enterotoxigenic agent causes a watery diarrhea. So it's similar to rotavirus, whereas enterohemorrhagic and enteroinvasive strains cause blood and mucus diarrhea. In the same way, the adenovirus, although it is listed as a watery diarrhea because being a virus, but it can sometimes be a little bit invasive and cause blood and mucus diarrhea with high inflammatory markers. If you look at the protozoa, Giardia lamblia and Cryptosporidium generally causes a watery diarrhea with acute infection because it infects the small bowel. But especially in children or adults, mostly with immune deficiency, it causes a chronic diarrhea with steatorrhea because of malabsorption. Entamoeba histolytica can cause watery diarrhea, but the classic amoebic dysentery contains blood and mucus. Right. Another the parasite that can cause blood and mucus diarrhea is Trichuris trichura, which lives in the rectum and the large intestine, and because it sucks blood, it can cause a blood and mucus diarrhea associated with rectal prolapse. Right, as I say, so we are in this lecture, we are going to mostly focus about acute gastroenteritis. There are 3 clinical syndromes that you might find. Acute vomiting, so it's predominantly vomiting with a little bit of diarrhea. So the classic history is the child goes nursery, and all of a sudden the child starts vomiting 6-7 times, goes into dehydration sometimes, but the diarrhea is not so much, and not much fever either. And it almost always, it is not always, it almost looks like food poisoning, right? But then you will find that to call it a food poisoning, you need to have the same food being eaten by several individuals and everybody going down with the same symptoms. But you will find that there might be other children with vomiting in the same nursery, but they haven't eaten the same food. So that is one type, classically seen with norovirus. Then you have what patiently described, where the child, it starts with vomiting several times, followed by massive amount of watery diarrhea. Child can go into dehydration. The fever is not much, and the abdominal pain is also not much. So this is the classic watery diarrhea. The best example would be rotavirus. Then you have children who are quite unwell. You have very high fever, severe abdominal pain, tenesmus, and of course diarrhea. And the diarrhea, compared to watery diarrhea, the diarrheal output is small amounts, but more frequently. Sometimes like 10 times per hour, you will have to go to the toilet. And even if you pass those, you don't feel like you have emptied the bowels adequately. And there's cramping pain, and the stools contain blood and mucus. So this is the classic dysentery, right? So these are the organisms I mentioned. So predominantly vomiting, norovirus, watery diarrhea, rotavirus, enterotoxigenic E. coli, cholera, which we don't see, Cryptosporidium, and endovirus. Then these are the DDs for blood mucus diarrhea, mostly bacteria. And of course, you will get Entamoeba histolytica as a parasite. And of course, as a virus, you will get endovirus. And as a worm, you might get Trichuris tricula, right? So you need to know some examples, right? They will be frequently asked in MCQs. Even I've seen, I mean, the examiners might ask you, even in the long case, okay, can you name 5 organisms that can cause blood damage because they're like that. So you should be able to answer it properly, right? Right. So these are, so this is an example for watery diarrhea. What you see in photograph A is rotaviral diarrhea. So it's mostly watery. Whereas in B, what you see is, which we don't see in Sri Lanka, thankfully, this is how the cholera diarrhea would look like. So that's why we describe it as rice water diarrhea. So this is the blood mucus diarrhea. So it might be like, altered blood like melena, or it might be like clear blood mucus diarrhea, or you might actually have more water with blood on it. Right. So especially in children who are less than 2 years, diarrhea can mimic lots of systemic infections. So we call them parenteral diarrhea. So it's not a term that you might find in textbooks, but most of your senior examiners will use the term parenteral diarrhea. So that is, something in the blood causing diarrhea rather than a fecal-oral origin. So certain conditions in the abdomen like interception, appendicitis, UTI can present as diarrhea. Then in small kids, especially who are less than 1 year, pneumonia can present as diarrhea initially without any lung sign. So you might just have fever and diarrhea. Even corona these days, the COVID-19 also these days, one of the commonest presentation in infants is fever and diarrhea. Then meningitis, sepsis, and certain metabolic conditions like diabetic ketoacidosis present like abdominal pain and vomiting. And of course, severe dehydration. So these are the 7 steps in management, which we will look at individually. So we'll discuss about how to manage vomiting. Then second thing is the most important thing. So in most of the times, the diarrhea management is fluid management, right? We'll look at the nutritional aspects. We'll look at the place of zinc in diarrhea. Then we'll look at the place of probiotics. And we'll look at how to prevent diarrhea. And finally, which is not very important, we'll look at antibiotics. So these are reserved for only blood mucus diarrheas of bacterial origin. So vomiting can be managed in 2 ways, right? So we can do physical measures, such as, you can, if you give small amount the fluids, especially something like Jeevani, which absorbs very fast in the stomach, you give small amounts more frequently. So even without any medication, that itself might settle the vomiting, right? Then of course there are several drugs which we can use. Common things that we use in the ward setup are domperidone. We do not use metoclopramide in children because of the severe dystonic reactions, but something that we use more and more these days is ondansetron. So about the use of ondansetron, I would like to introduce this major research that was done in 2016, where they took several thousands of kids and they randomly allocated them. So they took children who present with vomiting into the OPD or emergency department and randomly allocated them to the placebo group, domperidone group, or ondansetron group. So all these three groups, they were using physical measures, right? They were giving Jeevani or a rehydration solution, small amounts more frequently. So the placebo group did not get any medication, just the placebo. Then one group got domperidone, the other group got ondansetron. So in this study, what they found was, so they were looking at how long it took to settle the vomiting, how many of them required IV fluids, how many of them could be discharged from the OPD after a few hours of observation, and how many of them required admission. Like that, few criteria they looked at as outcomes, and they found that when considering the outcomes, the placebo group and the domperidone group had the same outcomes, which means domperidone was not the best, not very efficient at managing diarrhea. So, but the ondansetron group had clear advantage where they could discharge most of the patients. The vomiting settled dramatically, and they required less IV fluids. So, because of that, you'll find that most of the Western countries now they use domperidone as the first line. So domperidone is available as IV medications, it's available as oral tablets, it's available as sublingual forms, and the good thing is it is available as syrup. But we still use domperidone because in the government sector we don't get access to ondansetron frequently. So domperidone is available as syrup form, it's available as tablets, sublingual, and it's also available as suppository. So that is the advantage of domperidone. But the advantage of ondansetron is it's much more efficient compared to, or rather effective compared to domperidone. Right. So domperidone can be given for children who are more than 6 months. The dose is given. You don't need to remember the dose. You can just refer to the BNF. But the problem is ondansetron is that it is not something that we give regularly. Now domperidone, you may have seen when you are working in the ward, the house officers prescribe domperidone like 3 times a day, like regular dose. But ondansetron is not supposed to be given like that. It is given as PRN basis. Like if the child has vomiting, you prescribe ondansetron, and then you reevaluate and give only if it is needed. Because the reason is, if you give ondansetron regularly, like 3 times a day or twice a day, it will actually increase the diarrhea, right? And of course, these are rare side effects. So now, as I said, the fluid management is the most important thing when it comes to management of diarrhea. So there are 3 components in fluid management. Now, for example, if we took a patient, the 15-month-old child who presented with gastroenteritis and some dehydration, first thing is we need to correct the dehydration, because dehydration can be a killer. I'm not talking about some dehydration, but if it is severe, it's virtually an emergency, because if you don't manage it properly, the child might actually die due to complication. Then, so once you correct the dehydration, the diarrhea is going to continue, right? We will never prescribe medications to stop diarrhea. So whenever the child has diarrheal losses, you need to replace that volume. Now, Peshila said that the child passed. Peshila, are you there?
Yes, sir.
Yeah. How many times did he pass to us on the first day? 4 times.
Three times at night and 4 times in the morning.
Okay, so
1 time in the morning. So altogether,
roughly about 4 times. And you said the amount of diarrheal loss was equal to a yogurt cup, right?
Yes, sir, each episode. Yes.
So any idea how much is a yogurt cup, the volume?
About 200 milliliters.
No, 200 kilo sir. Tea bone cup 200 ml. So yogurt cup is around 80 ml if I'm not mistaken. So just make sure now, if you mention yogurt cup, the examiner might ask, okay, how much water does a yogurt cup hold? So it's about 80 ml. So that assessment is important in a way that's not very accurate. It's a visual assessment. But then you will know if each time the child has a diarrheal output of yogurt cup, you need to give at least 80 ml of Jeevani to replace it, right? So you need to, so second component of fluid management is replacing ongoing losses. And the third one is you need to, just like in any other illness, you need to continue maintenance fluid as well. So we will look at each component in the next few slides. So to correct dehydration, you need to know the dehydration level. So as I said, in WHO classification, either there is no dehydration or some dehydration or severe dehydration. So this picture taken from the illustrator So here you can clearly see the features of dehydration. So the child might be drowsy, or irritable. Fontanel, especially if it's a small baby, fontanel might be sunken. There may not be tears when the child cries. The mucosal membranes are dry. The child might be tachypneic, tachycardia with prolonged capillary refill time. Skin turgor might be reduced, and the urine output might be reduced. So this is how we test for the skin turgor. So if the child is severely dehydrated, this will not go back quickly. So usually it should go back to the normal position within about 2 seconds. So this is the clinical criteria to classify as some dehydration, no dehydration, no severe dehydration. You can look it up in the WHO guideline, but the practical aspect is if the child complains of thirst and asking for water all the time, that means there is some dehydration, right? So the child complains of thirst and readily drinks water, right? The other features may or may not be there. But if the child is drowsy, right? So here, maybe lethargic or drowsy and unable to drink, then you call it severe dehydration, right? So that's the easy way to remember. So if the child is having diarrhea or vomiting and the child wants water all the time and complains of thirsty, that is some dehydration. But if the child is drowsy and very difficult to feed, then of course, there is severe dehydration. So that's the easier way to remember, right? Rather than remembering all these things. So let's look at how we manage NOHA dehydration. Now, just give your attention to the number one part. So no dehydration. So that means we don't have to correct any fluids because there is no dehydration. So we don't have to correct dehydration. So only two components are there. So you give maintenance fluid and replace ongoing losses. So these children can be given home-based fluids. That's why I asked patient, did the mother know about any of these home-based fluids? So what are these home-based fluids? Home-based fluids should contain electrolytes. Best one would be king cod water. You can use soup, kanji, orange juice, lime juice, things like that. But Jeevani is, you don't have to give Jeevani regularly, but Jeevani can be given as a replacement fluid. That is, when the child has diarrhea, you give Jeevani to replace that volume. If you look at some dehydration, the second part, please give your attention to the yellow column. So when you have some dehydration, that is if the child has lots of episodes of water restores or vomiting, and the child complains of thirst and drinks water eagerly, then the child has lost at least 5 to 10% of the fluid. So we take the average as 7.5, right? And this amount has to be replaced. So now the question is, how do we convert the percentage to a volume? So each 1% equals to 10 ml per kg of fluid, right? So that's the formula. So if it is 7.5% here, 7.5 into 10 is 75 ml per kg has to be replaced to correct dehydration. Now, if you look at the child is 1 year and the child is 10 kilos, that comes to 750 ml. Or if you take patient's patient, the child was about 8.5, so 8.5 into 75, so roughly somewhere around 600 milliliters has to be replaced, and the time period is 4 hours, and you try and replace it with G1, right? But you have to be practical also. Now let's take the example of a 10 kilo child coming with some dehydration. We need to give 750 ml. So the instructions should be clear. So the mother should be said, okay, this child should need about how much? About 200 ml or maybe slightly less than that per hour has to be given. And maybe you can even refine and say every 10 minutes you need to give this volume, so that the mother can easily keep track of the amount of fluid that the child takes. And at the end of the 4 hours, you need to reassess the child. If the child still has features of dehydration, you need to correct it. But if the child doesn't have any features of dehydration, then you manage as no dehydration, where you replace the ongoing losses and give the maintenance fluid with home-based fluids. Now, we are now looking at the red part, that is severe dehydration. As I said before, this is an emergency. So here you have 10% loss. So if you calculate, convert the percentage to the volume, it comes to 100 ml per kg. But 100 ml per kg is a very big volume, right? You can't give it quickly because the child might go into fluid overload. So you give it in two phases. So in the first phase, you give 30 ml per kg, right? In the second phase, you give 70 ml per kg, so that altogether you get 100 ml per kg. In small kids who are less than 1 year, you correct it over 6 hours. So in the first hour, you give 30 ml per kg, whereas the rest of the 5 hours, you give 70 ml per kg. The child is more than 1 year, of course, you can correct it pretty fast. In the first half an hour, you give 30 ml per kg. The rest of the next 2.5 hours, you give 70 ml per kg. So if the child is less than 1 year, you correct it over 6 hours. If the child is more than 1 year, you correct it over 3 hours. Remember, because it's an emergency, you don't use ORS or any of the oral fluids. This has to always be corrected intravenously. If you can't get IV access or intraosseous access, then of course there's a place to put an NG tube and give Jeevani. But almost as much as possible, you try to correct IV, at least intraosseous access. So once it is corrected, you can manage as no dehydration. Is everything clear before we move on to the next point? I mean, if anybody has any question about this management, the acute management of diarrhea, please, you may ask, or you can even type in the chat box, right? Anybody?
Excuse me, sir.
Yes, please.
Yes, sir. IV fluid can only use in severe dehydration only.
Very good question. So if it is severe dehydration, there's no question. But if it is some dehydration, there are occasions, like even in this case, we had given IV fluids. I mean, because it has to be corrected by Jeevani, right? If the child doesn't take Jeevani, then of course, there's no other option. So then you can give the same volume intravenously. So 75 ml per kg over 4 hours can be given intravenously. The child is not taking Jeevani, right? Is that clear?
Yes, thank you.
Okay, good. Right. Now, how do you replace ongoing losses? If you know the volume, like in Pachel's case, so he has visualizes that each time the child passes about a yogurt cup, that's roughly about 80 ml. Then, of course, you can replace that volume. But if you don't know the volume, especially if the child is wearing diapers, you have no idea how much you are losing, unless, of course, you start measuring the weight of the diapers. So this is a rough guide. So if the child is less than 6 months, you can give 50 ml of Jeevani. Remember, replacing ongoing losses, always Jeevani, right? If the child is more than 6 months, up to about 2 years, you can give 50 to 100 ml of Jeevani each time the child passes stool. If the child is between 2 to 5, you can give about 100 to 200. Beyond that point, you can give as much as you want. So this is something a bit difficult to remember, but the easier one to remember is 10 ml per kg. So if it's a 10 kilo child having a watery diarrhea, you can give 100 ml. If it's a 20 kilo child, you can give 200 ml. This is each time the child is passing stools. Now, maintenance fluid, we have already discussed. These are some of the home-based fluids that we can use. Now, these are things that are commonly given. Now, I'm sure even at your homes, people take coffee with when there's diarrhea. Now, if you look at the mechanism of fluid absorption, you know the fluid should have electrolytes, right? The sodium should be there, and glucose to a certain extent should be there. That's why Jeevani has 1:1 ratio of sodium and glucose. But if it doesn't, if the fluid does not contain electrolytes, sodium, then that water will not get absorbed. So coffee is not. That's why coffee or plain tea will not be a good source. Carbonated drinks, like people generally give like cream soda, those sort of things, because children like to eat, but because it doesn't contain salt, that fluid will not get absorbed because carbonated drinks will only contain sugar. Fruit juice, especially apple juice, is not a very good rehydration solution because it has lots of sugar, more than electrolytes, and the diarrhea might actually get worse. Right, now we are going to, so we have looked at how to manage vomiting, we have looked at how to manage fluids. Now we are going to look at nutrition. Now, nutrition is very important during an episode of diarrhea. There are lots of misconceptions among Sri Lankans. Sometimes they don't give eggs, they don't give meat, they don't give fish, thinking that the child may not be able to absorb these things. So because of that, a child who's like, borderline failure to thrive, like, somebody maybe at the range of moderate acute malnutrition, after diarrheal episode, the child might actually drop into the range of severe acute malnutrition. So our duty is not to let this happen. At the same time, there's something called antidiarrheal foods. There are, again, these are beliefs where people believe that certain foods might help diarrhea. Now, okay, so these are some of the things how to maintain nutrition. The most important thing is once the diarrhea is over, once the appetite is regained, you need to give one additional main meal instead of the normal number of main meals, right? Right. So solids, as soon as the dehydration is corrected, you have to start solids, and these should be easily digestible ones. So you can give more frequently in small amounts. And once the diarrhea is over, you need to give one additional main meal. Right. Now, as I said, there are certain food items which might be good in diarrhea. These are not scientifically proven, just traditional ones. Even, okay, a few things about nutrition. Okay. In Western countries, there's something called bread diet, where you give banana, rice, apple sauce, and toast. In Sri Lanka, we also have similar concepts. So we give anamalu. People believe that when you give anamalu, it has the capacity to absorb water from the stool, so that the water loss is minimal. And anamalu also has potassium, as you probably know that when there's diarrhea, lots of potassium is lost. Lime juice, yogurt, rusk. So if you go to the once you start clinicals, if you get a diarrheal patient, you will find in the BHD the nurses have prescribed diarrheal diet. So there's something called diarrheal diet. So this is what they get: anamalu, lime, yogurt, and rusk. Well, there's always the question about whether you should give a lactose-free diet. Of course, especially with the rotaviral diarrhea, the small bowel, will I get atrophy. So if you give too much lactose, the diarrhea will persist. So it's always better to cut down on milk. But if the child is only breastfeeding, you should not do that, because if you try to do that, then the child will go into malnutrition. Right, now we look at the place of zinc. Zinc has three distinct advantages. It reduces severity by 30%, reduces duration, and reduces recurrences. So you need to know the three reasons why we prescribe zinc routinely. The dose is, if the child is less than 6 months, you give 10 milligram of elemental zinc. Remember, this word elemental is very important. I will tell you why. Beyond 6 months, you give 20 milligram of elemental zinc, and you generally give it for 10 to 14 days. Now, why I'm highlighting this elemental part is, now this is a fairly common, this photograph is of a common multivitamin or zinc preparation that is available, called Zincovit. For some reason, this is the almost all the GPs prescribe Zincovit instead of proper zinc. Now, if you look at this composition, I want to highlight is that it says zinc sulfate 20 milligrams, so 5 ml. So if you don't know about this elemental zinc business, you will prescribe this child, okay, I need to give 20 milligram of zinc. So this says that there is 22 milligram of zinc sulfate, so I'm going to give 5 ml daily for the next 10 days. But the thing that you need to know is this part. So this is the whole molecule, zinc sulfate, but only 1/4 of this is zinc. So here the elemental zinc is actually 5. So if you try to give the required zinc amount, suppose the child is 1 year and you need to give elemental zinc of 20 milligram daily, and if you are giving Zincovit syrup, you need to give 20 ml of Zincovit. Yes, that is fine. I mean, the child takes, that's fine, given 20 ml. But the problem is there are other vitamins. So Zincovit has other things like, sometimes it doesn't mention here, sometimes even fat soluble vitamins. So you will be overdosing them. So you should not give, this is actually a label from Zincovit B. The normal Zincovit has even vitamin D also. So you should not give 20 ml because you will be overloading them with other vitamins, right? So because of that, in the hospital setup, we have zinc tablets, right? So when we go to the hospital, just check from the nurses and have a look at the zinc tablet. So this is a water dispersible tablet, so you can dissolve it in water and give. So each tablet contains 20 milligram of elemental zinc. There are of course certain syrups like Zevac, Zincoplast. They also contain pure zinc with the recommended strength. So each 5 ml has 20 milligram of elemental zinc. So if you are prescribing zinc for iron, make sure that you are prescribing the right medicine. Now we are going to look at probiotics. Probiotics again are routinely used, but if you look at the evidence, since we practice evidence-based medicine, you don't have enough evidence to prescribe probiotic, because the evidence is that it reduces the duration of diarrhea by 24 hours, and also it reduces the hospital stay by 1 day. But in a country like ours, this is still useful because a probiotic sachet costs about 100 rupees per day. But if you stay in the hospital for one additional day, that might cost the government about 4,000 rupees. So prescribing probiotics, although it reduces the duration of diarrhea by 1 day, still worthwhile giving it, at least in hospital admitted patients. So the sixth important thing is prevention. Now, this is in this history is a clear example, right? The neighbor had diarrhea, and it got carried over to the other house. So prevention of diarrhea is very important, right? These are some of the steps that you can take. Exclusive breastfeeding prevents diarrhea, and that's why we recommend it up to 2 years. Exclusive breastfeeding up to 6 months, then continuing breastfeeding up to 2 years. The food hygiene and water hygiene, hand washing, very important. Now, one important thing is, now you need to, if you ever see a diarrhea patient, remember to wash your hands with soap and water, because nowadays with the COVID pandemic, we try to use alcohol rub for everything, but some of the causes for diarrhea like adenovirus or Clostridium spores, and especially norovirus, they are not killed by alcohol. So that's why you need to wash your hands with soap and water. Immunization, now rotaviral vaccine is available in the private sector. You give it, it's an oral live attenuated virus vaccine. So it's given at 2 months and 4 months, 2 doses. It definitely reduces the rotaviral diarrhea, reduce the incidence of diarrhea up to 1 year. There's a rare side effect of interception. But unfortunately, this is not available in the government sector. Now, antibiotics, as I said, we don't routinely prescribe antibiotics, especially before water diarrhea. Other than cholera, you don't need antibiotics. It might actually worsen the diarrhea. But for blood-brain mucous diarrhea, although rarely it is caused by adenovirus or Entamoeba histolytica or trichuria, we still prescribe antibiotics because commonly these are caused by bacteria. This you need to find out. In developed countries, especially UK, USA, they do not give antibiotics for blood-brain mucous diarrhea, even if the organism is E. coli or Campylobacter. I want you to find the answer for this. Maybe you can read a little bit. Probably it is there in the illustrated also, because illustrated textbook was written in UK, so probably they would mention the reason behind that. So this is some homework for you. But in our setup, because of the organism that you get are different, you need to give antibiotic, because if you don't give antibiotic, the complications are more. So how do we decide on the best antibiotic? So of course, you need to take stool for culture. Then the culture report will tell you what is the best antibiotic to use. Unfortunately, the child might be too sick, or there's no time for us to wait till the culture happens. Culture report is available, so you will have to start them on empirical antibiotics. So how do we decide on the empirical antibiotic? So every 3 months, the LRH microbiology unit issues a report like this. The sensitive pattern of stool cultures and blood cultures. So, for example, this is the sensitive pattern in 2018 August. So you can decide on the antibiotic based on that. So some occasions we use cefixime or third generation oral cephalosporins or cefuroxime. Sometimes we use nalidixic acid. Sometimes we use furosemide, cotrine. Like that, we decide on the empirical antibiotic based on this culture reports that we get every 3 months or so. So make sure that you go through these reports once you start your clinicals again. So little bit about antidiarrheal medicines. As I said, we never prescribe antidiarrheal medicine. So with drugs like loperamide for acute diarrheas. So although in commonly adults, we give these sort of antidiarrheal medications, but we do not recommend them in children simply because the side effects are more than the advantages. So the bacterial, if it is a bacterial infection, the infection is going to remain because there's no natural mechanism of getting rid of this bacteria by increased stool output, and it can cause fatal paralytic ileus and toxic megacolon. So do not prescribe drugs like loperamide for acute diarrhea. For chronic diarrhea, yes, there's a place. I mean, if you get a patient with chronic diarrhea, you will find that sometimes we put them on drugs like loperamide, but not for acute diarrheas, especially acute infectious diarrheas. So few complications. Water diarrhea, the main problem is there's a lot of water and electrolyte loss. So you get dehydration when you are severely dehydrated, and if it persists for a long time, you can end up with acute kidney injury. You get venous thrombosis, especially if you're polycythemic. You get children with cyanotic heart disease who are polycythemic. So so we are very careful when cyanotic heart disease children get watery diarrheas because they might get sagittal sinus thrombosis. And watery diarrheas also can cause electrolyte disturbance, especially hypokalemia, because the diarrhea will contain a lot of potassium. Now, dysentery, blood and mucus diarrhea has a different set of complications. Certain organisms can cause systemic infection, especially Shigella can cause meningitis, sepsis, endocarditis, osteomyelitis can be caused by Salmonella. Then they can cause seizures due to different mechanisms. So, for example, it can cause electrolyte imbalances such as hypokalemia. There can be Shigella, especially can cause a meningitis. And Shigella, without even causing meningitis, there is something called Shiga toxin, which can cause seizures. Hemolytic uremic syndrome is a dreaded complication. Although it's fairly uncommon, we see 1 or 2 cases every month. So you might, I mean, these days, of course, we don't see many patients, but we used to get at least 1 patient with hemolytic uremic syndrome. There is something called reactive arthritis, especially we also call it Reiter syndrome, where you have diarrhea or dysentery, and you get most of the time it's a knee joint swelling. Guillain-Barré syndrome, especially with Campylobacter, you can get, and of course glomerulonephritis. So you will have to read a little bit more. So that comes to the end of my presentation, right? If you have any question, you may ask now. Right. Do you guys have any question? Or if you can't talk, or if your mic is not working, you can actually type in the chat box. Anyone? All right, if you don't have any question, we will conclude the session now. A few things. Now, Prof. Pujita and Prof. Shaman had decided not to have on-site teaching for the next week. So we are going to develop a online timetable. So probably we'll have. Okay, there's one question by Nafis. Sir, do we give IV bolus in severe dehydration? Yes. For example, if you take a 2-year-old child, the first part is by giving 30 ml per kg over half an hour. So that is a bolus. Now, usually, this is actually a bigger bolus than that we give in sepsis. Now, in something like sepsis or dengue shock, we give 20 ml per kg or 20 to 30 minutes. But here in 30 minutes, we give 30 ml per kg. So that bit is called a bolus. Just the difference in terminology. Yes, so to answer your question, yes, we give bolus in the first 30 minutes. Now, let's get back to what we were talking. Now, so I'll prepare a timetable and share it with the monitor. So you can discuss with the relevant consultant and decide on the time. Especially as everybody is doing Zoom teaching, the peak hours are going to be very busy. So especially from 9 to 12, and then 2 to 4 o'clock are going to be very busy hours. So we will probably have to do it off hours. So Prof. Pujita usually starts his class around 7 o'clock. So you will have to wake up a little bit early for his classes. Then I will probably do it later the day. I mean, maybe around 8 o'clock, 9 o'clock. I mean, let's decide. I mean, I'll discuss it in Malaka and let you know. And Malaka will have to discuss with individual lecturers and decide on the time. Now, what we need to decide is about the IWC. IWC is an online event, so worthwhile